Clonal accumulation and proliferation of myeloid dendritic cells. It may represent a true malignancy or immune dysregulation. Characteristic feature of Langerhans cell histiocytosis is Langerhans cells along with lymphocytes, eosinophils, and giant cells. Depending on clinical presentation, previously it was divided as Letter-Sive disease, Hand-Schiller-Christian disease, and eosinophilic granuloma. Letter-Sive disease, it is most aggressive. It has a rapid and fatal course, and it is also called acute disseminated Langerhans cell histiocytosis, usually seen in children of less than 2 years of age. It has multi-organ involvement. Hand-Schiller-Christian disease, it has a typical triad of skull bone defects, diabetes insipidus, and exophthalmos. Age of presentation is between 2 to 10 years, and it might present as a vague clinical presentation like fever, diffuse eruption, bone lesions, and lymphadenopathy. Eosinophilic granuloma, the presentation is different in children and in adults. In children, it is unifocal, and it might present as lytic lesions in the bone, which might be asymptomatic or painful. Whereas in adults, it presents as pulmonary Langerhans cell histiocytosis, which is usually associated with smoking. Coming to epidemiology, around 2 to 10 cases per million population has been noted. Below 15 years of age, and median age being the 3 years is the age of presentation. In Indian population, about 5 to 10 patients per year have been reported. When there is a family history of malignancy, there is higher incidence of developing Langerhans cell history. Etiopathogenesis, it might be due to defect immune system regulation or reaction between Langerhans cells and T cells in response to triggers. Triggers being infection in case of children, and in adults may be smoking. And BRAF gene mutation. BRAF gene is a proto-oncogene whose mutation can lead to abnormal proliferation of these Langerhans cells. Clinical features, it has a variable presentation. Clinical. Clinical features. It has a variable clinical presentation. It might vary from low-grade persistent disease to rapidly progressive fatal course. Or there might be vague symptoms like fever, malaise, weight loss, failure to thrive. Specific features are present when a particular organ system is involved. The most common organ system involved in LCH is skeletal system. Around 80 to 100% of patients have skeletal system involvement. Flat bones being more common than long bones. Hands and feet are almost never affected. They might present as lytic lesion with soft tissue swelling, and when there is vertebral lesions, they might present as compressive neuropathy. In chronic cases, they also might present as pathological fractures. And in case of chronic ear discharge, there might be destruction of mastoid area. These are the lytic lesions over the skull. Skin involvement. 35 to 50% patients have skin involvement. They might present as difficult to treat seborrheic dermatitis, brown to red papules with central ulceration in case of infants, and hypertrophied gums, which may eventually lead to maxillary or mandibular lesion and cause hypermobility of the teeth, leading to floating tooth or loss of tooth. Sometimes they might present as petechia and hemorrhagic lesions. The first picture shows a red to brown papillar lesion with central ulceration. Second is of eczema dermatitis. And the third picture is a eroded hypopigmented papillar lesion. And the last two pictures are blueberry muffin rash in a neonate. These muffin rashes are multiple, firm, non-blanching purpuric rashes. Coming to the next system, that is gastrointestinal system, there might be hepatomegaly. When there is hepatomegaly, it might lead to biliary radical involvement and can cause sclerosing cholangitis. When there is involvement of spleen, it might lead to hypersplenism, which eventually leads to pancytopenia and in some cases respiratory failure. And one of the clinical presentation is diarrhea and malabsorption of unknown cause. Lymph node involvement. This is usually seen in Indian population, being cervical lymph nodes the most common. Sometimes it might mimic infection. Coming to pulmonary features, about 10 to 15% of patients have pulmonary features. Pulmonary Langerhans histiocytosis is more common in adults than in children. When it is inward, it is usually symmetrical and might present as cystic or nodular pattern due to cytokine-induced damage. These cysts might coalesce to form bullae, which might eventually rupture to form a pneumothorax. And in some cases, there might be fibrosis and respiratory failure. This is a HRCT of chest showing multiple cystic lesions bilaterally and parenchymal damage. Endocrine system. The most common presentation might be diabetes insipidus due to posterior pituitary damage. And when the anterior pituitary is inward, there might be growth failure, hypogonadism, or adrenal insufficiency. There might be involvement of thyroid gland, which might lead to primary hypothyroidism. In eye, it might lead to exophthalmos due to retroorbital accumulation of granulation tissue. When there is bone marrow involvement, there might be thrombocytopenia and anemia, and in some cases, hemophagocytosis may be seen. This is usually present in children. CNS features, it might present as a mass in hypothalamo-pituitary axis, or it might present as a neurodegenerative disease. Neurodegenerative disease, it might be an abnormality in MRI or neural dysfunction coming with complaints of cognitive impairment, ataxia. The risk factors being the skull lesions in, lesions in skull bones. This is the picture of MRI showing a lesion in pituitary gland. Coming to investigations part, we can do baseline evaluation, then lab findings and radiology, and going to the specific test. Baseline evaluation, it consists of a thorough history. We might ask for the history of chronic ear discharge or difficult to treat scalp lesions. Clinical examination, we have to examine skull and skin also. Not to forget CNS examination. Lab and radiology, there is no specific feature as such. We have to do the routine investigations like complete hemogram, LFT, KFT, and ESR, and chest X-ray in case of pulmonary Langerhans histiocytosis, and skeletal survey to look for lytic lesions in any other part of the bone. Coming to specific tests, we do these tests when a particular organ system is involved. Like when there is an abnormal chest X-ray, we can go for HRCT and pulmonary function test. If that is also abnormal, then we can go for lung biopsy. And in case of chronic diarrhea and malabsorption of unknown cause, we can go for endoscopic biopsy. When there is liver enzyme derangement or hepatomegaly, we can go for USG whole abdomen and later liver biopsy. In case of CNS lesions, we can go for MRI brain with contrast, and endocrine evaluation is also must. Definitive diagnosis of LCH is by demonstration of Langerhans cells with reactive infiltrates consisting of eosinophils, lymphocytes, and macrophages on histopathological examination. We can also find Bobek granules, which are tennis racket-shaped granules on electron microscopy, or immunohistochemistry for CD1A and CD207. The first one is a picture of Bobek granules. These are tennis racket-shaped granules. And the second one is CD1A positive staining HB. Provisional diagnosis can be made when there is lesions with S100 positivity with any one of these positive, ATPase, alpha-mannosidease, or lectin. Before going to the treatment part, the patients are divided into 3 groups. That is based on risk organ involvement. Risk organs being hematopoietic system when there is anemia, of less than 10 hemoglobin, thrombocytopenia, and lymphocytopenia. And liver when there is hepatomegaly of more than 3 centimeter, or deranged liver enzymes, or edema or hypoalbuminemia. Spleen when there is splenomegaly, and in case of lung, abnormal chest X-ray. CNS risk lesions, lesions in skull bones with soft tissue extension. Based on these organ involvement, the patients are stratified as group 1, that is multi-system risk patient, in which there is more than or equal to 1 risk organ involvement. Group 2, multi-system low-risk patient, which is multi-organ, multi-system involvement, but there are no risk organ involvement. Group 3, this has a very good prognosis, which is being single system multifocal bone disease and localized special site involvement. The special sites being skin, lymph nodes, and bone. Treatment based on the groups, it is divided as like this. For group 1, we give 2 months of induction therapy followed by 12 months of continuation therapy. Group 2, 2-month induction followed by 6-month continuation. Group 3, 1-month induction followed by 6-month continuation. The drugs being oral prednisolone, 40 mg per meter square, vinblastine, 6 mg per meter square IV bolus, methotrexate, 500 mg per meter square 24 hours infusion, and supportive measures like antiemetics. In case of anemia, we can go for PRBC transfusion, IVIG infusion. Recently, there have been investigations going for BRAF inhibitors. Response and follow-up. Follow-up for 5 years after stoppage of therapy. Initially, there will be very frequent follow-ups being 6 weeks, then followed by 6 months, and then every year for 5 years. This can be done by clinical examination, routine blood investigations, and radiography. Prognosis, when it is a localized lesion and when skin, bone, or lymph nodes are involved, it has a good outcome. Whereas when it is multi-system or liver and CNS involvement or children less than 2 years of age, it has a very poor outcome. Langerhans cell histiocytosis is a very rare disease, but when patient presents to us with difficult to treat skin lesions or lytic bone lesions, we can consider Langerhans cell histiocytosis as one of the differential diagnoses. Thank you.
Because you have read this subject for the last 7 days, and idea of having a seminar is to teach others more. So first is your speed. Because now you go back. Go back to the first time. So you can see.
First of all, she has done a reasonably good job. It was not 7 days. She has literally made this presentation in 24 hours. So, you have talked well. So, LCH is not a very uncommon disease. It's not a very uncommon disease. We don't know whether it is by default or it's a referral center. We do see a lot of LCH with varied presentation. So, whenever it's a persistent symptom, it's not fitting the other diagnosis. It can be just persistent fever, weight loss. It can be like, as she said, that it can be cervical lymphadenopathy. Often they are being treated as tuberculosis outside. They're getting ATT drugs. So it's not resolving, or the lymphadenopathy is progressing further. We need to consider the DD of LCH. Plus, we have the lytic bone lesions. There may be lumps or bumps, or there may be a lesion that you can feel as a depression in the bone. And the skin lesions. She was mentioning the skin lesions. Another typical aspect of LCH is that it involves the palms and the soles also. So one of the few diseases, like when you think of disease of skin lesions involving the palms and soles, papular lesions, you have to think of LCH. And as mentioned, the seborrheic dermatitis, persistent seborrheic dermatitis, you again think of LCH. We saw a lot of children also with GI symptoms, persistent diarrhea, recurrent dysenteries, and especially when there is liver involvement. Liver involvement can be of two types. One can be per se LCH involvement, which may lead to deranged LFTs. And there is a progressing sclerosing cholangitis. So basically they present with deranged LFTs, liver failure, progressive jaundice. So again, it's a DD of LCH. And these are bad. These are the ones that are bad LCH. As she was mentioning that the GI involvement is bad. Usually the children are present in infancy with persistent diarrhea. We lost one kid, less than 1 year old, who was having persistent diarrhea. And similarly, we had another kid with progressive liver failure due to sclerosing cholangitis. He was being taken up for liver transplant at SSKM hospital, but before that, unfortunately, he succumbed to the disease. So that was regarding the presentations. So this particular classification is mostly redundant now. This is of historical value. Now, according to the treatment perspective, more important is we classify as single system or multi-system involvement with or without risk organ involvement. So our treatment depends basically on that particular classification. This is almost redundant. It's like relegated to just MCQs and quizzes, I guess. So about the BRAF mutation, BRAF mutations is interesting to us now. It's almost present in 50 to 60% cases. So this is being added to the BRAF. It's a BRAF mutation. No, sir. It's BRAF, and more specifically, we have a point mutation V600E. So that's the mutation that's most common around 50 to 60% cases of LCH. And so when we are doing histopath now, whenever we are doing the biopsy, it's preferable to do the mutation study also, because we have a targeted therapy available to us. Bemuferanib is an oral drug. It's available to us. So in case of refractory or a difficult to treat LCH, we can go on to the targeted therapy of bemuferanib in case if this particular mutation is positive. She hasn't put in the pictures of like the palms and soles being involved. That's again a striking, very striking characteristic of LCH rashes. Nails are usually spared. Nails are not involved in case of LCH. Usually it is spared. And about the lungs, the change that has happened in the recent protocol is that lung was included as a risk organ in the previous protocol along with the bone marrow, liver and spleen. Right now in the current protocol, lung is not included as a risk organ. So the treatment changes for that. And yes, they present with recurrent spontaneous pneumothorax. So you have to be very careful. Somebody LCH with a lung involvement, known lung involvement, coming into the ER with respiratory distress, do a chest X-ray or look auscultate just to see if the air entry is proper or not. Often they usually blow up new pneumothorax and come desaturating. So again, we will insist that not an FNA, we need a biopsy, information with the immunohistochemistry. CD1A marker CD207 is actually Langerine, and Langerine is again Berbeck's granule, which is very specific for Langerhans cell. And also we have S100 among the other CD markers. So we need biopsy, IHC, and if possible, also now we have the BRAF mutation as we discussed. If possible, we can also go ahead with the mutation study, especially with the smaller kids, because usually they have refractory LCH to begin with. So here, as I mentioned, the lung has gone out of the risk organ involvement. Bone marrow, liver, and spleen remains. That is about it from us. If anybody has specific questions.
I want to say that we must have very good threshold for my experience. intractable cervical to be wet to the supply and it's not responding. Think of once and souls being treated as caries very common and then more importantly, the red mix spots that you see in the diaphragm area. That's again very classical. I remember a patient, especially presented with diarrhea, hospital, then not responding. I'm not a very good clinician, but somehow or other on that day, I checked the baby of 2 3 months. And then immediately I started thinking for one of the presentation for LC. Right. Check for that and then come back to the end. Bone lesions are quite common and we see a lot of cases like that's more in the children study.
Yeah, and the other important thing is it's a single system involvement, only bone lesion. We can just monitor the patient. The patient may not need any
Single bone lesion you nothing. Single finding.
Yeah.
Like that picture.
You just monitor.
We want to
No,
You
we
want to
will
anything,
monitor.
but you need to keep an eye.
Yeah.
Suppose they can
Act
you know,
What's
it can be a
skeletal
tuberculosis also. A single lesion can be a tuberculosis of the nose, can be histiocytosis. It might be LC, and I can form in a normal parietal foramen.
Tuberculosis is osteomyelitis.
Tuberculosis of the bones. And then parietal foramen. And the other differential diagnosis.
Parietal foramen is normal.
Yes,
Normal.
it's a normal. It's very well circumscribed. Similar to the well circumscribed that we see in the barbell operation. Someone has done a barbell. Huh? Yeah, it's a so the barbell operation keeps seeing the comes out. These are very common exercises, especially nowadays. That's indicable what the differential. Whenever there is tuberculosis, there is histiocytosis. Let's see each or that group that was separated from the character for important. I think it's just in the region of the country. And we have seen Shubham is the case. I think he's being treated now as message. Being treated as message.
Diagnosis was like.
Manchester is very specific.
Sir, but yeah,
Patient presented chest and fever. He was given antibiotics in the hospitals. He came to me, and normally I don't agree to that. So I admitted the child care. The CT scan and everything. Nothing was happening for tuberculosis. The fever continued, and then suddenly the patient developed. Things could be like. Then we did an MRI, and MRI showed that there is a lesion. Then the patient developed with Cns Features, something moving more than 600. So we were all thinking of tests were not possible. So we sent the patient to because the patient has an endocrine problem, and that's one of the common presentations of LCH. They said our patient has just simple. But we are working with adults. So they say this, but there was no bone involvement in that patient.
But it's biopsy proven as the specific IHC markers was not consistent with LCH and consistent with Organ-Chester.
But there was no bone
No
involvement.
bone.
That's very characteristic. That is almost the impossible. So, but ultimately, whatever it is, the treatment is similar almost. So I insisted that she can't have steroids and then likely she didn't agree, but
Not that I agree that I send you the article, but I guess the patient wasn't well also.
not that these not nagging, I would say, apprehensive about everything. So I think the child is better now.
I do know, sir.
I will have to refer also. So, other limitation, as you said, likely that limitation. There was all this location in the chest X-ray. Patient is on vancomycin, and processing. And normally we have worked up. Before leaving, patient was in the ICU. Opened up the door and found that the outside food was classic of the disease. I said, this is last one. The disease and investigate and we can see. So, clinical examination, complete clinical examination. What is favorite? You go up, you forget about it. That's what we do sometimes. But we can do it with our experience. We have to do for how much to do for the beginners, the total clinical examination.
How common is multiple myeloma?
Never think of
That's the cause of
Either I will not discuss much because the examination is now
Lesions actually restricted
Scarlet lesion would be specifically base of the skull bone. That is called a CNS risk lesion. Base of the skull bone involvement, or the lesion is like impinging on the dura. There's a soft tissue involvement pressing on dura. So those are CNS risk lesions. Otherwise, Voltaire we just like level constructs. Those are partial presentation not to be
that
treated.
patient was in the base. We went for biopsy of discovery was in favor, but in the list of the rest was not really. However, they remember that they are being treated as LCH or steroid.
What's the PDF version of
You see,